Start.
Okay, so welcome everyone. I am Dr. Vishwanath. I am consultant neonatologist in KIMS Cuddles, Kondapur. So before starting, can we just introduce ourselves so that we know, where you are from, what you are doing. Yourself, sir. Saiteja.
GMC
Sangareddy. Okay, hi, welcome.
Sirisha sir, GMC
Sangareddy, welcome.
Rajkumar sir, Mamata Medical College.
Mamata Medical College, welcome.
Kashmira sir from Star Hospitals.
From Star Banjara, welcome.
Aparna,
Sir.
Medical Officer in National Disaster Response Force.
Okay, welcome, sir.
Yourself? Sir,
Neelofar Hospital, okay. Yourself?
Sir, RVM Medical.
RVM Medical College. Ma'am, you?
Sir,
Neelofar. Okay, fine. So this is, welcome sir, we are just introducing. Can you just introduce so that we all know?
I am Rahul sir.
Ah.
Ankura.
Ankura,
Madhya.
Madinaguda. Neonates workstation. So we'll be discussing about, mainly about CPAP and NIPPV in this station. So CPAP will be having ventilator CPAP and bubble CPAP both. Okay. So to start with, we'll start with CPAP. Okay. So we'll have this as an interactive session. We had, with previous this thing we have interactive session. So what is CPAP? It's a continuous positive airway pressure, right? So what does it do? CPAP. So it gives a constant distending expiratory pressure, okay, which is applied to a spontaneously breathing neonate. The spontaneously breathing is very important. Okay, so you give a constant distending pressure by, it will be a heated humidified gas which gives an distending pressure to a spontaneously breathing neonate. So that's how you give CPAP to any baby. So now, how does that help? CPAP, how does that help in a neonate? Very good. Yes. Yes. So, if you see the mechanism by which the CPAP works, if you see in the proximal airways or the large airways, it decreases the resistance. It splints the airways, so it decreases the resistance, so that the airflow is easy without any resistance. Okay. So in the upper airways, this is the mechanism by which it acts. And in the alveoli, it helps in maintaining the functional residual capacity. Okay, it maintains the FRC, and by which it prevents the alveolar collapse or the atelectasis. Okay, it helps in keeping the alveoli open. So which in turn results in an improved gas exchange across the alveoli, right? And it prevents something called as VQ mismatch. So in preterm babies, we see a lot where the lung is atelectatic or the collapse. It results in lots of VQ mismatch. VQ mismatch is when your alveoli is collapsed, it is not ventilated, but it is perfused. Okay, so it leads in a lot of VQ mismatch. So CPAP helps improving in VQ mismatch also. Okay, and it also helps in stabilizing the chest wall. The preterm babies, if you see, the chest wall is very compliant, it moves a lot. Okay, so it helps in stabilizing the chest wall, by which it decreases the work of breathing. Okay, and something called as it stimulates the stretch receptors. Okay, so it helps in inspiration also. So these are all the ways by which a CPAP works. Okay, so now we know what CPAP is, what mechanism of action of CPAP is. Now we want to see how a CPAP can be delivered to a baby. So what are the CPAP options we have? What are the types of CPAP we have? Obviously all of you must be using CPAP, bubble CPAP. Okay, so we broadly categorize it as, something called as continuous flow CPAP or variable flow CPAP. So continuous flow CPAP is the CPAP which you give through ventilator and also through bubble CPAP. These are the continuous flow CPAP. Now where there is something called as variable flow CPAP, where the flow of the gas changes, okay, through inspiration and expiration, and the generation of pressure is by something called as infant flow driver. Okay, so we are not using very commonly that. We are using this continuous flow CPAP, of which the most common is bubble CPAP and CPAP through the ventilator. Okay, So we will see how a ventilator CPAP and a bubble. I think we'll discuss bubble CPAP first because it's being very, we use it quite a lot. So for bubble CPAP, we have something called, we have to give an air and oxygen source, right? So the air is by gray or black and your oxygen is through white. So those two tubings comes into connection with this blender. Okay, so the blender mixes air and oxygen and then it delivers. You can titrate the FiO2 how much you want to deliver from 21 to 100%. Then we have a tube, we have a flow meter which is attached to this blender. Okay, here you can adjust the flow. Okay, usually for CPAP we keep a flow of around 6, 7 or 8 liters per minute flow. And then from this flow meter a small tube goes into humidifier. This is the humidification chamber and this is the humidifier. Okay, from the humidifier you have an inspiratory limb which is denoted in blue in color, and then you have an expiratory limb here which is the white, and then expiratory limb is immersed in something called as bubble chamber. It is filled with water. Okay, so the pressure generated at the interface at the baby's end is based on the depth of insertion of your expiratory limb. So the pressure is generated in the expiratory limb. Okay, if you want to deliver a PEEP of 6, you immerse this tube to a depth of 6. Okay, and then if you have to give a PEEP of 5, so you take it out at 5. So the depth is very important. That's how you decide the PEEP which you want to give. Okay, and then this is the patient interface. I mean, this is a flexi trunk of Fisher and Paykel, and then you have a mask. This one is a mask. Here you have, based on the size of the nose, you can decide which mask to use, and then we fix it there. So if you see here, now you can see the bubbling happen now because I have closed it completely, so the bubbling can happen. So it means that the CPAP is delivering well. Now if there is any displacement at the patient's interface or patient's nostril, then the bubbling won't be adequate. See, if baby is moving, the interface has displaced, so the CPAP won't deliver as effectively what we want. Okay, so ventilator CPAP is slightly different from the bubble CPAP, where in ventilator CPAP you have an expiratory valve which stops the flow of the expiratory gas flow, and then it generates the peak inspiratory pressure, peak expiratory pressure. Okay, so now when you come to a ventilator, you have a display like this. So when you start, you have invasive mode, you have non-invasive mode, and then in non-invasive you have NCPAP, you have NIPPV, and then you have nasal high frequency ventilation. And then if you press on this, and then now you can see we have kept a PEEP of 8. Okay. So now you can see. So this is a base 0. You can see it is a baseline. Okay, and in this y-axis, you can see the PEEP 6, 14, 22 like that. Okay. So here the PEEP, this is the line where you can see this much is the PEEP being delivered. In the display also, numerical value also you can see around 8, 8.2. Here is the FiO2 which is being shown, and the flow liters. In SLE we cannot adjust the flow. It comes in inbuilt thing in the SLE. Flow adjustment is not there. But one additional parameter is this PIP. Okay. In CPAP we don't give PIP, but this is for the backup. Suppose if baby goes into apnea, we will have an apnea alarm limit which is set. If the alarm limit you have kept as 15 seconds or 20 seconds, and if baby doesn't take a breath for 15 or 20 seconds, ventilator detects it as apnea, and then it gives a additional PIP on PEEP for the rate which you set as backup rate. Suppose you keep a backup rate of 35, 40. Okay. So if baby is apneic continuously, ventilator will deliver 40 of PIPs in 1 minute. Okay. 40 of 18 PIP it will give in 1 minute. So it is for a backup thing. Okay. So this is the how you give a ventilator CPAP. So you have any queries or about ventilator or bubble CPAP you want to ask?
Indications of CPAP in ventilator.
Yeah, we will discuss that. So now we know what is CPAP. We know what are the effects, what are the mechanism of action of CPAP, and now you know we can give by ventilator and you can give by bubble CPAP. So now there comes to indications of CPAP. In which set of babies, neonates, you want to give CPAP? So basically, what are the indications of CPAP? So respiratory distress syndrome in preterm babies, you want to give CPAP? Yes. Then apnea of prematurity, very commonly used, very common indication to start CPAP. And then post extubation respiratory support in preterms and term babies you want to use. And in term babies, few indications like transient tachypnea of newborn, some meconium aspiration. While using in meconium aspiration, you have to be little bit cautious where you tend to keep slightly lower PEEP, where because the lung has various zones where there are atelectatic, there are hyperinflation is there. So you tend to keep a lower PEEP because the risk of pneumothorax is little bit high. Okay. Then in which set of neonates you want to avoid, or you are not very keen on starting CPAP first? Like you can say for contraindication, but very good, CDH. So congenital anomalies like your choanal atresia, your cleft palate, and your congenital diaphragmatic hernia, tracheoesophageal fistulas. In those set of babies, you want be using CPAP upfront. Then what? We discussed in the starting that CPAP has to be in a spontaneously breathing neonates. So in neonates who are not spontaneously breathing, so CPAP is not that effective, right? So in those babies also CPAP won't be serving the purpose. Next, which set of babies you don't want to consider CPAP to start with? Then is if a baby is in shock, pure shock, hemodynamic compromise is there. In those babies, CPAP won't be of much help. So these set of babies you want to not use CPAP upfront. You can choose other mode like NIPPV or your invasive mode of ventilation based on the sickness of the baby. Okay. Now coming to next mode is NIPPV. So what is NIPPV? What is NIMV? What is NIV? So it's almost terminologies are same only. Okay. Non-invasive positive pressure ventilation. Okay. NIMV, NIV, all are similar terminologies only. So now, what additional benefit we have of NIPPV over CPAP? PIP. So peak inspiratory pressure is additional on CPAP. So what additional benefit it gives over CPAP? The PIP. So if you see, once we change it to NIPPV mode, so here you can see it is PEEP. This is the scalar, flow scalar. This is the PEEP, and this is the pressure scalar where you can see the PIP also. So how does that help? So it helps in increasing the mean airway pressure. So NIPPV also has same benefits what CPAP has. On top of that, it slightly gives more mean airway pressure, okay, which helps in your better oxygenation, your better ventilation, okay. So these are the additional benefits which you get.
5 minutes more.
So yeah, over CPAP, these are the additional benefits you get of NIPPV, okay. And there is something called as Head's paradoxical reflex which is seen in NIPPV. It is like when the PIP is peak inspiratory pressure is given to the larynx, it stimulates inspiration in a baby. So this is called as Head's paradoxical reflex. It's a physiological thing which happens when you keep on PIP. Okay. So these 2-3 things are additional benefit of NIPPV over CPAP. Okay. And then indications of non-invasive positive pressure ventilation is, it's the same thing. Like you can keep in respiratory distress syndrome, you can give in apnea of prematurity if you feel that there are recurrent apneas and all, and then you can keep in post extubation support. Okay, post extubation respiratory support in preterms and term babies, and in term babies you can use it for meconium aspiration or other congenital pneumonias, early onset sepsis and all, you can use it. Okay, so one thing I wanted to this is like so all of you must be using the interfaces. Which interfaces you are using? Masks, cannulas, prongs, cannula, Ram's cannula you are using. So yeah, it's very widely used. We have Ram's cannula here. So this is Ram's cannula. Okay, and then we have mask also, and then we have something called as prongs. This is just for your understanding. Okay, so this is a size guide of Fisher and Paykel mask, and this is called as flexi trunk. What you see here in this one is the flexi trunk. Okay, this is the interface flexi trunk, and then you connect the mask here. Okay, the size of the mask is very important because you need to optimize the delivery of CPAP or NIPPV based on how acutely you can how properly you can seal the mask. Okay, so the center part you see it's a small size, medium size, large size and XL size. Okay, you can just try to place on the top of the nose and see which size the baby's nose fits into well. Okay, and then you can decide which mask size to be taken. So this is the mask size. Then the same you have is the prong size also. Okay, here you can see the little white dots. Can you see that white dot circle? So these are the nostrils, and then you have the columella distance in between. Okay, one this number coding is for nostrils and for the septum also. Okay, so these based on you can just place in front of the nostril and see which size fits into well, and based on that you can take, and you have to make sure that the interface fits snugly to the nose. That is very important for delivery of CPAP or NIPPV. Few side effects, not side effects I would say, but few things you have to monitor while baby is on CPAP. So what all things you want to monitor when the baby is on CPAP? So objective measurement, I mean that is like optimizing CPAP. You want to see that after keeping CPAP, your objective assessment, like your SAS score has come down, baby is clinically better, your saturations are well, episodes of apnea has come down. Yeah, so that is you have to have objective measurement of distress, SAS score or Downey score, whatever you are comfortable with. That has to improve. Okay, but if it is not improving and you have reached to a PEEP of 8, FiO2 reached beyond 50, 60, then you consider it as a CPAP failure. Okay, then you need to step up on your respiratory support, be it NIPPV or be it you have to go for an invasive mode of ventilation. Okay, so few things, monitoring is, one is the clinical monitoring of adequacy of respiratory support what we are giving. The next is suppose even baby is comfortable with these settings, there are some side effects of CPAP, like then you can see something called the CPAP belly. Because of the gas flow, the stomach gets distended. There may be some feed intolerance associated with it. Okay, and the most important thing is if you are using a mask or a prongs, you need to see the nasal injury. So there is a nasal score for the injury also. So you need to keep a track of that. Effectiveness wise, mask and prongs both are more or less same. Okay, but little bit of septal injury and this thing is seen more with your nasal prongs. Okay, but delivery wise, effectiveness wise, both are more or less same. Trans cannula is also equally efficacious. It is cost effective. It is being widely used. Okay, and effectiveness also is same. Okay. So you want to ask anything? Any doubts? So all of you are using CPAP, NIPPV in your unit, workplace? Done. Okay, yeah, we are done. Okay, fine. Thank you then. Yeah. This is water tap for excessive water which gets condensed. It is in the expiratory limb. Okay. So when the HME filter in the expiratory port. Okay. This excessive water gets trapped. We have to frequently, drain the water out. Okay. Right. Thank you all. Yeah.
If you want to put 8 5,
It should be inside.
ఇది 6 million. ఓకే,
వాటర్ రాకుండా ఏం చేయాలి సార్? నార్మల్గా రెగ్యులర్గా వాటర్ వస్తూనే ఉంటాయి.
ఇది ఇన్స్పిరేటరీ లిమ్ లో ఆ వాటర్ రావద్దు. ఇట్ మీన్స్ దట్ ఇది మన మీది టెంపరేచర్ సెన్సార్ ఉంది, దీని మీద వాటర్ డ్రాప్లెట్స్ ఏమైనా ఉన్నాయా అనేది క్లియర్ చేసుకోవాలి. ప్లస్ ఇది వార్మర్ దగ్గర ఉండాలి, మరి బయట ఉండొద్దు. ఓకే, వార్మర్ బేబీ దగ్గర ఉన్నట్టు చూసుకోవాలి. ఓకే,
రెగ్యులర్గా వాటర్ వస్తూ ఉన్నాయి.
సో ఇవి ఒకటైతే హీటర్ వైర్ వల్ల ఇష్యూ ఉంటుంది. మోస్ట్లీ దీంట్లో ఏదైనా వాటర్ డ్రాప్లెట్స్ స్టక్ అయి ఉంటే అది రైనింగ్ అవుట్ అవుతుంది ఇన్స్పిరేటరీ లిమ్లో. ఓకే, 36.5 because we use invasive mode of this thing. 36.5 is ideal. Okay, because it is at this end. You are at the patient end. If you see, ఎప్పుడు వస్తుంది here, because it is not connected to the baby, so it will be humidifier. We are using distilled water only.
Nothing else should be used, or
No, prefer not to use distilled water or sterile water, these two things. Okay.